Hi everyone, in this video I'll give you a brief overview of diabetes insipidus. For some key background information, diabetes insipidus is a metabolic disorder which typically presents with the triad of polyuria, polydipsia and dilute urine. So a patient wheezes a lot, drinks a lot, but the pee is still very dilute. It does not deal with glucose absorption issues directly, such as the other types of diabetes, such as type 1 or type 2 diabetes. There are no issues with insulin, despite the name. But the main two reasons for diabetes insipidus is firstly lack of ADH or vasopressin, which means that there is no hormone that could act on the kidneys to cause the urine to be concentrated, or there is a resistance of renal collecting ducts to ADH, also called vasopressin, which is the reason why the urine doesn't become more dilute. In terms of the etiology, cranial diabetes insipidus is often idiopathic, so no exact cause can be found. However, tumors such as craniopharyngiomas can cause it, as well as pituitary surgery or radiotherapy to the area, which causes damage to the pituitary, and hemochromatosis. Again, this is all due to the fact that the pituitary produces ADH or vasopressin, and when it's damaged, the production ceases, which is why you get the symptoms. In nephrogenic diabetes insipidus, the ADH is produced by the pituitary just fine. However, there are issues with the kidneys actually recognizing it and acting on it. And those can be genetic reasons, such as ADH receptor mutations. Electrolyte disorders, such as hypercalcemia, can induce it. Or medication, such as lithium, can also cause it to occur. In terms of the clinical presentation, you have the core triad I've mentioned before of polyuria, polydipsia and dilute urine, but you can also get other symptoms such as nocturia or having to wee a lot at night, visual field defects, which would be typical in patients presenting with pituitary tumors, or signs of volume depletion such as dehydration, dry mucous membranes, low blood pressure and increased capillary refill time. Again, this isn't an exhaustive list because it depends on the underlying etiology in each patient, but these are some of the things you should look out for. In terms of the investigations, the first one is urine osmolality, and it should be low in a patient with diabetes insipidus, and it should be less than 300 millimoles per kilogram, roughly. Water deprivation test is probably one of the key tests, and it is diagnostic of diabetes insipidus. You deprive the patient of fluids for 8 hours and check for dehydration. And in non-diabetes insipidus patients, the urine osmolality goes up. So it should go to roughly 700 millimoles per kilogram. However, in those who do have diabetes insipidus, it would stay at below 300 millimoles per kilogram, even though they've not been taking in any water for this prolonged period of time. Another test worth doing is the ADH stimulation test, and it is key in order to determine whether the issues are with the pituitary or with the kidneys. In cranial diabetes insipidus, you would see an increased urine osmolality. This is because the kidneys work just fine and the receptors are there, but there's been some issue with the pituitary, so not enough of the hormone has been produced, which would then result in the urine concentrating when you give some ADH. In nephrogenic diabetes insipidus, you would see no change in urine osmolality. That means there is already enough of the hormone circulating around, but the kidneys are not recepting it and not understanding it, resulting in no change to urine osmolality. In terms of the final test that can be done, a 24-hour urine collection test would show over 3 liters of urine produced in patients with diabetes insipidus. But how do you manage each type? Well, with regards to nephrogenic diabetes insipidus, you would use diuretics such as benzoflumethiazide, or you can also make sure that there's maintenance of adequate fluid intake. In cranial diabetes insipidus, you need to first find the cause. Is it hemochromatosis? Is it related to surgery, or is there a tumor perhaps present? And you can also give synthetic ADH such as oral desmopressin in order to treat cranial diabetes insipidus. That is all I have for you today. I hope this brief overview of diabetes insipidus was useful. If you have any comments, please leave them down below, and I'll hope to answer any questions you might have. Other than that, thank you so much for watching, and I hope you consider subscribing.